by the time you enter that perimenopausal phase, right, and your ovaries are kind of starting to fizzle out and they're not making enough estrogen. So you start to have all these estrogen fluctuations, right? That certainly starts to happen. But even prior to that, so let's say if the average person is entering perimenopause in their mid-30s, well, their testosterone deficiency is the first to go.
What if I told you that the same mindset that builds championship teams also builds an extraordinary life? The same discipline that drives elite performance to greatness is a discipline that unlocks a longer, stronger, and more resilient future. This is where peak health meets peak performance, where we explore the science of longevity and the mindset of greatness. Because your legacy isn't just what you leave behind, it's what you show up with every single day. This is the Legacy and Longevity Podcast. I'm Zach Dancel, your host. Before we dive in, I want you to know this is part one of a two-part deep dive into women's hormone health. Today, we're tackling the 2002 Women's Health Initiative study that scared millions of women away from life-saving therapy and why the timing hypothesis proves early intervention works. Part two covers testosterone, peptides, and complete hormone optimization. Now let's get into this episode. Welcome to the Legacy and Longevity Podcast. Today's episode will be slightly different than normal programming. Today, we're going to talk about something that we at Nava have built our foundation to optimal health and longevity for the last 12 years. There may be no other medication or therapy in modern history that improves the health outcomes of women on a population level more than hormone therapy. And in my opinion, this is one of the biggest medical travesties of our time. An entire generation of women and doctors have been scared away from not only life-changing, but life-saving therapy. And not because the science or the data said that it was dangerous, but because the study was misdesigned and misinterpreted. And because of that, the headlines would impact millions and millions of lives. I'm Zach Dancel, Chief Operating Officer at Nava Health. Alongside me is Stephanie Misanik, Clinical Director. And we've spent the last decade working side by side with our medical team, our medical directors, and spent years of learning and educating ourselves from some of the brightest minds in the hormone space. With doctors like Dr. Doug Lord and Dr. Angela DeRosa with over 70 to 80 years of combined experience in the hormone space. So today, to kick us off, before we get into the nitty gritty, Steph, just kind of give us a little bit of education around women's health, perimenopause, menopause. What is it? When does it occur? And what's happening?
Well, thanks for having me. I think this conversation in general is incredibly important, and especially in this space right now with the zeitgeist. Everybody's all pro hormones now, which we gotta take advantage of that and make sure that the proper information and education gets out to folks, because part of how we got into this problem or this space to begin with is because of misinformation, right? There's not all of a sudden new science that broke all this stuff down. This science has always existed. It's a misinterpretation and misutilization of what's out there, and poor representation from the media. So I think it's important, like, before we even dive into all these nuances and nitty gritties of hormone replacement, we got to talk about what is menopause? When does that start? What happens kind of like in that transition into menopause? Because I always have found, and, again, I've been talking to patients for so long, a lot of people don't even know the phrase perimenopause, right? And so menopause is often the only thing we talk about. But if we're just talking about menopause, we're missing a huge part of that conversation, right? So let's kind of define things a little bit. So menopause, to officially be considered in menopause, you as a biological female have to have a full year with no menstrual period. And that's your actual menopause diagnosis, right? And that happens in 1 second, right? You've reached that year, you don't have the period, now you're menopausal, congratulations. But the thing that is missing from this conversation is the 10 to 15, sometimes even longer year period that a woman goes through transitioning to the point where she has not had a period for a full year. And that's the part that is never a part of this conversation. And we have to talk about the timing of that, right? We think about, when you think of menopause, Zach, like what age do you think of for women going into menopause? Like what age woman do you picture in your head?
Yeah, I'm going to picture someone who's in their 50s, 60s, around that age.
Right. So I think that's most people's picture, right? And I've had conversations with folks about this before, that they're shocked to learn that transition often starts in the mid-30s, right? So mid to late 30s, we start that perimenopausal transition. Again, it's a 10 to 15-year transition, and then you're in full-blown menopause when you don't have that period for a full year. But there's so much that happens in that transition, and it's so much deeper than just no longer having a period. And that's what we're going to talk about a lot today. And I just think, it just bears to say, and this is important, because of, like you mentioned earlier, and, in the intro, one of our mentors in this space, Dr. Angela DeRosa, one of the things that pushed her into this space as a clinician is during her residency, which was, in her mid-20s, she started having some serious heart palpitations and, was running treadmills and passing out and had full-blown syncope. And, she was told she did all the EKGs and all the cardiology workups, and then everything came back unremarkable. And she was just told to, stop being so stressed out. But it turns out she was in early menopause, right? So those early menopause folks, the folks that actually become full-blown menopausal in the mid-30s, backtrack 10 to 15 years. Those folks are often starting, this perimenopause phase in their mid to late 20s. Why is this conversation important? It's important because if you are, let's just take the average woman, not the early menopause woman. If you're a woman in your mid to late 30s, and you're beginning that transition into perimenopause and eventually into menopause, you're going to have a whole bunch of symptoms that have nothing to do with hot flashes and night sweats, right? By the time you get hot flashes and night sweats, you're basically menopausal. That's the very end stage of perimenopause. But there's so much that happens before that, right? The brain fog, the lack of focus. Like, I can't remember where my keys are. I can't remember my kids' sports schedules. I can't remember when that meeting is supposed to be. That's what starts to happen. Then we see shifts in just body composition, right? So we'll see more increased central adiposity, more weight gain in the midsection. And a lot of this is happening not just because of estrogen going all over the place, but, once you're in that perimenopause phase, you for sure have a testosterone deficiency. So your blood sugar and your glucose metabolism is all out of whack. So you start to have insulin resistance and you start to have weight gain. Right? You start to have more inflammation in general. So it's a transition that leads to no periods and hot flashes and night sweats in the end, but it's a bigger conversation. And I think that's an important point to make.
Yeah, so let's just kind of summarize and break that down, right? So menopause, the definition is 12 months without a cycle. And when that officially happens, right, that basically means your ovaries have completely shut down and you're no longer producing estrogen or progesterone. The perimenopause phase is the transition, right? Which you just said that could start 10 to 15 years prior to menopause. So what people are presenting and what doctors are telling, uh, you know, people who are coming to them with these side effects, right, is uh, what is really a hormonal imbalance, is ultimately being, misdiagnosed and mistreated for things like antidepressants, anti-anxiety medications, sleep disorders. Um, so the perimenopause phase, right? Let's talk about what is happening to, a woman's hormones during that phase.
Yeah, that's a good question. And I'm actually really glad you asked this because it's not linear. It's not a linear, like, very slow, steady, progression into menopause. It is a legitimate roller coaster, right? And I think there's a few things to talk about. One is, by the time you enter that perimenopausal phase, right, and your ovaries are kind of starting to fizzle out and they're not making enough estrogen, so you start to have all these estrogen fluctuations, right? That certainly starts to happen. But even prior to that, so let's say if the average person is entering perimenopause in their mid-30s, well, their testosterone deficiency is the first to go. So testosterone is going to plummet before you hit full-blown perimenopause, right? So usually we see testosterone start to drop in the early 30s, and that's not even part of the conversation. And I'm sure we'll get into that later. But so we see that happen. So in it, you start to have these estrogen fluctuations, right? When estrogen is a really important molecule, a lot of times it gets a bad rep. But estrogen in and of itself is wildly anti-inflammatory and neuroprotective. So when you start losing estrogen, you lose those two benefits, and then you get all the negative impacts downstream, right? So if you no longer have that neuroprotection, well, there's the brain fog, there's the focus issues, all that kind of stuff. When you lose that anti-inflammatory piece, there's the increased cardiovascular risk. There's the increased, brain health, like symptoms like depression and brain fog and things like that. Because again, you don't have that anti-inflammatory effect of estrogen, not just in the body, but the brain is part of the body, right? So estrogen is anti-inflammatory to the brain as well. So a lot of times those perimenopausal women, like your original question, I think was what is the symptomology of those patients, right? So they'll first start to present usually with mood disturbances is generally what we see. I'd say mood disturbances and weight gain tend to be like the first two things that people complain about in their mid to late 30s. So they're doing the same thing they've always done. They're eating healthy, whatever that means. We can have a whole other conversation around that. They're working out, they're exercising, they're doing all the right things on paper, but their body is shifting. They're gaining weight. No matter what they do, they can't get the weight off their midsection. No matter what they do, they're not able to put on weight muscle in the gym. No matter what they do, they have this like consistent brain fog, and they can't focus and think like they used to. And I'm sure we'll talk about this at some point, but this is really important, because if you go to a doctor and you're a 30-some-year-old woman and you go to your doctor and you bring these symptoms up, the last discussion that's going to happen is around hormone imbalance, right? We're seeing a massive increase in ADHD diagnoses in middle-aged women, and I would bring to the table, is that really happening, or is it a loss of or an impact to executive function due to the loss of testosterone and estrogen? That seems much more relevant, much more obvious to me than all of a sudden out of nowhere we have massive increases in ADHD diagnoses to the point that we're having stimulant medication issues, like fulfillment issues.
Well, let's talk about it. I mean,
Yeah.
the study that we're getting ready to dive into, the Women's Health Initiative, done in 2002. Um, so it's about 23 years ago, right? And when that happened, the medical education, you know, stopped, and even if they did, then they stopped educating providers and doctors on hormones. I'm sure they talked about the different phases of the perimenopause, menopause phases, but hormone therapy wasn't a discussion had, right? So, as you mentioned, people and women are going to their doctors presenting with actual hormone imbalance, perimenopause symptoms, but yet because of the lack of education and the lack of knowledge in the medical schools, that there's a huge gap there that you know is causing these providers or causing these women to be misdiagnosed and mistreated. It's symptom management versus treating the root cause. Um, so I think that's obviously something that we'll get into as well. But I think that's also critical to kind of bring up just the lack of education that is provided to our medical providers. Most of the stuff that we're going to be talking about today, the providers who are trained and educated on it, right? They had to do it on, outside of medical school, right? Attending different conferences like we kind of, the IFM, A4M, finding, experts in the field, like we mentioned, Dr. Angela DeRosa, and Dr. Lord, who they themselves went out and sought the education and knowledge that they needed to help the clients that they were seeing on a day-to-day basis.
Yeah. I think this is like a sensitive topic and I'll share my true feelings about it, which is that you're right. Menopause and menopause education and women's health education in general is severely lacking in medicine. It's almost like the second nutrition, right? We you and I have spoken before. Doctors don't get nutrition training either, right? And so this is another version of that. They just don't get the training, But I think I think at some point though, regardless of whether the education is happening or not, and we can have a whole topic on why the education is not happening, right? It's not happening because there's no money in it, and that's a whole other path that we could go down. But I think too, like, it becomes the responsibility of a good clinician to keep themselves up to date. And so this is where the doctors do have responsibility in this, right? They do have a personal responsibility. There's no lack of research. I remember, again, hours and hours and hours of you and I both have sat in medical trainings to really understand this. And, Dr. DeRosa and I used to, just hours talk about this stuff to really understand it. And she would say the same thing. There's a big issue in medical doctors and other, clinicians not taking that personal responsibility and staying up to date themselves. And so then you end up having, fast forward 25 years after this study that we're going to dive into, right? So there was a study that came out in 2002, Women's Health Initiative. It was a very poorly designed, misinterpreted study. The media went crazy with it and created all this fear around hormones for women. And a lot of physicians fell into the same exact trap that just the average, consumers, the average population was falling into. And that's unacceptable, right? As a clinician, you have a responsibility to keep up to date, to really understand the latest research, and to have those kinds of conversations with your patients, and again, like you and I have been doing this for so long, and we have talked to so many clients that have come through the doors of Nava, where they go to their doctor and they ask for, a simple conversation, a simple little set of hormone labs just to get a little picture, or a simple conversation around hormone replacement, and it's immediately shut down, and they're immediately gaslit. And that's not conducive to health and, longevity and all those things. And so the doctors have to be held responsible to a degree. It's a poor study design and poor media coverage and all that, but doctors also, they played their role.
No, I definitely agree. There comes a responsibility for providers to do no harm, but I also think this is hormone therapy is one of the prime examples of the gender disparity that we have in modern medicine. Um, just the lack of training, the lack of knowledge of a population that's over half of the population, right? 51, 52% of the world is women, and so just we can get into the gender disparity later on just the huge gap that's been created there based off of men's physiology versus women, which obviously very different, right?
Very different. We're a little bit more complicated than you guys.
And a little bit more complicated. I won't say anything to that, if my wife's listening.
Every
But
way, I'll say it for you.
at the end of the day, we can't live without you guys, right? And you guys should be treated just as fairly when it comes to such um, life-saving treatment and therapy.
Yeah. Well, and also, Zach, at the end of the day, and this is kind of silly and a bold statement, but at the end of the day, if the roles were reversed, right? If in your let's say in the whole 40s decade for men, right, was a period where we slowly cut off your testes and cut your ability to produce, the world would fall apart, Zach. Right? Everybody would be lining up to create solutions for that, right? You just but we have it happen for women, and they're just like, oh, you're depressed, go on the sleep pill, go on the Xanax, go take this Adderall, and good luck to you. It's wild how it's just not part of the conversation, and you can see that in pharmaceutical drug development, right? So
Yeah.
let's just look at like let's just take a simple topic, sexual dysfunction. How many solutions are out there for men for sexual dysfunction? Right?
I think when we were looking at it, might be like 15 or 17 approved applications.
So many, right? You guys have pills, you have creams, you have devices, you have shockwave therapy, you have all kinds of stuff that you guys can use, to promote sexual function. And by the way, some of those drugs are not benign, right? Viagra, those drugs are not benign drugs. That took a lot, millions and millions and millions of dollars to get the studies on that, to get that pushed through the FDA and all that stuff for approval, right? And then not to mention, men have over 30 different FDA-approved testosterone formulations, right? And do you know how many the FDA has approved for women?
Zero.
Zero. We got nada, right? So we have nothing. So, and I don't, not only that, but it's not even a conversation,
Right.
right? And that is such a glimpse into the gender disparity in gender bias that's happening in medicine, that the issue is not even acknowledged, let alone addressed. But for men, it very much is. And some of that is, historically, studies are not often done on women because we are more complex, right? So there's kind of two reasons studies are not done on women. One, we're more complex, and so it's too much, right? And then two is that if we happen to get pregnant during that study, that creates a lot of ethical issues and whatever. So that those are the main two reasons we don't have boatloads of research on this stuff for women. But at some point, somebody has to stand up and say enough is enough, right? And that's what we're here to do today.
Yeah. And not to toot our own horn. Uh, I will.
Yep. Yep.
because um, I couldn't be more humble to work for a company like Nava that has been shouting this from the rooftops for the last 12, 15 years. Not just about the foundational thought process of optimizing hormones for anti-aging, longevity, treating any chronic conditions or symptoms that you're currently dealing with, but also to help bridge the gap of that gender disparity, right? Dr. Lord, was a former OBGYN for over 40 years, delivered over 5,000 babies, right? So he's in the thick of women's health, right? Navo started because, my mom got really sick, and part of her issues were she had hormone imbalance, where doctors, were mistreating her for perimenopause, menopause symptoms that, they were putting her on all these medications, right? And so, like I said, going back to just Nava, being able to work for a company who's just been ahead of the game for so long, as well as helping bridge that gap and bring a voice to women's health, because at Nava, women make up about 65 to 70% of our clients, right? So clearly, um, we are, there's a different scale there, right? Where, we are primarily helping women versus men, even though there's all these approved applications out there for men. We have made it very important for us to, making sure that, women are getting uh, just as much benefit and care as men are.
Yeah. Well, and I think too, to add to that, because you're absolutely right, but to add to that, we have to talk about the fact that, there's not just to treat women, but to treat women, appropriately, to give them the best possible outcomes, to help them be completely optimized, and to do it in a really safe and thoughtful way, and to do it in a way where there's like a conversation.
Yeah.
This is one of the things, and this about me, I'm very not tolerant about this kind of stuff, but all these telemedicine companies, things that are popping up, and because hormones are popular, and now they're starting to get some traction, which is great, right? Like any kind of voice in this space, we're happy about it. We want to bring awareness, we want to help people, but I do want to make sure the general public knows that there is a way to do this that's safe, and there's a lot of people that are all over the place doing all kinds of wackadoodle things with hormone replacement. And if I'm talking to right now, like my aunt, my sister, my mother, my grandmother, right, whatever that is, I want them to go to a place that, one, has the experience, right? They're not just writing prescriptions and calling it a day. They have the experience, they're monitoring lab work, they know that monitoring and treating hormones is so much bigger than just shooting for a number on a lab. If any provider is saying, oh, we just shoot to get between this range, and that's the only way we look and analyze and see if this is working, then you need to run, because that's not somebody that knows what they're doing. And I think that's really important. So that's what we've built over the past 12 years. You and I, again, we've sat and trained, and all of our medical providers have trained with these professionals, and we've sent them, and done trainings all over the country on this stuff, and spent hours and hours and hours and hours really perfecting protocols, and understanding that bigger picture of not just what do your labs look like, right, but what does your hormone metabolism look like, what do your detoxification pathways look like, what's your nutrient status look like, are you gonna, also, by the way, what does your thyroid look like? Because if you don't address and assess and treat thyroid, and you're just pumping people full of sex hormones, then you're going to make them worse.
Yeah.
Right. So it's a much bigger conversation. And I think that's why we both feel so passionately about chatting today, and just making sure that the right information gets out to the right people. Because there's a lot of charlatans doing a lot of crazy stuff, and it's important we do it in a safe way.
Yeah. I mean, it's important for people to understand and realize that, when you're searching for a hormone provider, you got to make sure you do your research and you find that expert, right? That they have the education, they have the experience, they have the knowledge to truly manage and do hormones at a level where it's precision and personalized based to you, um, and not just treating you as a cookie cutter, right? Don't find a provider who's just checking the box of just being able to say that they can sell testosterone and GLP-1s. No, find someone who knows what they're doing, who can give you the best benefit, who can give you the best outcomes and do it safely, you know, uniquely to you, right? It's again, it's not a cookie cutter model. You know, hormones and GLP-1s, when used inappropriately, can be very dangerous, right? At the end of the day, this is still medicine, right? It is not something that you want to mess around with. It's not someone that you want to take a guess with, right? When it comes down to managing your hormones, yeah, I think hormones are the foundation to longevity. I'll say that, you know, every day, all day. There's nothing that's more foundational, you know, on that population level than hormones. But it comes with having the knowledge, the experience, and providers who actually know what they're doing when it comes to how we optimize, what ranges we're going for, how to manage and mitigate any side effects. Because, you know, in medicine, there's always going to be some sort of side effects. So, you know, we got to make sure that we have the tools in in our tool belt to be able to overcome those side effects, which they can be, right? You know, like if basically if we become estrogen dominance because we're
Estrogen metabolism.
estrogen metabolism, you know, it's you know there's you know our body is going to detox and push our testosterone to estrogen, and we want to make sure that it's going down the proper channels and in the proper pathways. So again, it is complex. It's not as easy as people make it out to be. Oh, let me just go down to the you know this site and get my testosterone script. No,
It's not that simple. And let's talk about too, Zach, because you and I, I'm laughing because once I say this, you're going to jump on it, right? This is going to shock people, but not all doctors know about hormones, right? Not all endocrinologists are hormone experts, right? Most endocrinologists are not hormone experts. I know that's confusing to people. Most OBGYNs know nothing about hormones. OB-GYNs are trained on procedures, and they're surgically trained, right? That's what they do. Um,
no, I mean,
and
Dr. Lord tells us that all the time.
yeah.
OBGYNs don't have a clue about
Yeah,
hormones.
I'm gonna blame it on Dr. Lord.
Yeah,
That's right. I'm not
blame it
blaming
on
you.
him. Yeah, so it's not us saying it, it was him that's saying it,
Yeah, yeah. For the
but
record, it's Dr. Lord's fault. No,
but
I'm
no, I
just
mean,
kidding.
that's as much as I want them to, you know, be more educated on it, that's fine, right? You know, just find a place like Nava Health or, you know, a provider who is an expert and does know
Right.
what they're saying. So, I think that, you know, is enough of the intro and, you know, let's jump into the nitty-gritty, right? The Women's Health Initiative, you know, the study
Study that broke everything.
that, you know, the study that broke everything, that, you know, just, um, what exactly is the Women's Health Initiative, right?
Yeah.
And why did it create so much fear?
Yeah. So the Women's Health Initiative is a study that came out in the early 2000s, right around 2002. And it was a study on, to look at the safety and efficacy of hormone replacement for women. But there's so much wrong with it. And this is being talked about everywhere. So, it's important that we address it and we kind of break down what's wrong with the study. Why was it misinterpreted? What role did the media play in it? And just kind of, debunk some of the fear that came from that study. But the basics are that, it was done on the wrong population, right? So most of the women in that study were average age of 63 years old. You yourself earlier said the average menopause is, early to mid 50s, right? So at that point, these women are already 10 plus years into menopause. Why does that matter? That all the impact of having the hormones lost, all the massive increase in inflammation, all the reduction in antioxidant capacity, all that damage has already started, right? So it's just like any other disease process, right? Once it starts, it's a lot harder to slow down and turn around and reverse, right? But if you can get in there early, then you have more of an impact. You can have more benefit, and we could talk about that later. So that was the first thing: study the wrong people, the wrong women, the wrong age, and that's important. The second thing is it used the wrong hormones, right? So they use synthetic hormones. They used horse estrogen and synthetic progestins, and those come with significant side effects. We don't use those in medicine, even in conventional medicine. Those are not used anymore. Really, that specific type of synthetic hormone. And why does that matter? Because they're not bioidentical. And bioidentical just is not a scientific term. What it means is biomimetic, right? So what we do at Nava is we only do bioidentical, meaning or biomimetic hormones, meaning from a molecular standpoint, the structure of those hormones that we're giving you are identical to the hormones you have in your body. Whenever I put anything in the human body, whenever any of us put anything in the human body that is not naturally occurring, it turns on some kind of inflammation, right? The body responds with an inflammatory response because it's not supposed to be there. So it is important that you're doing the proper, form of hormones. So that's the bioidentical. And then it's the wrong route, right? So it used oral hormones, and oral hormones, anything you put in your mouth that you swallow has to go through the GI tract. It goes through the liver. It turns on that clotting cascade, and you're going to increase your risk for blood clots. When you do a transdermal application, so like a cream, for example, or even a subcutaneous pellet, which we love to do here, and we can talk about that too, because pellets in general are also a controversial topic. Those are going to be the best routes, right? So that we're not turning on that clotting cascade. And by the way, we're also getting better absorption, right? Pellets are going to have nearly 100% absorption. If I'm giving you something orally, by the time it goes through all the rigmarole of your GI tract, you're absorbing maybe a tenth of that medication. So not only are you increasing your risk with the clots, but you're just not really absorbing it, right? So that's kind of what was wrong in a nutshell. Wrong people, wrong form, wrong administration, wrong route, wrong everything. Um, and then the media ran with it, right? In terms of those results, they misinterpreted the results and then they ran with it and they really scared people.
Before we continue, I want to share something deeply personal. The real reason my family started Nava Health. Over a decade ago, my mom was on her deathbed. Her organs were failing, and the doctors told us there was nothing they could do except keep her comfortable. In that moment, everything changed. We realized traditional medicine had limits, especially when it came to proactive and preventative root cause medicine built for long term health span and lifespan. At Nava Health, we take a data driven precision approach to longevity. We test over 90 biomarkers to uncover exactly what's happening inside your body, and we build a personalized plan designed around your unique biology. Because fatigue, brain fog, weight gain, they're not random, they're signals. And when you listen, your body can heal. This is functional longevity medicine done right, comprehensive, proactive, and built to help you feel and perform your best at any age. Go to navacenter.com and take control of your health today. Now back to the show. We got the wrong time, women well past 60, which you kind of just laid out for us, after menopause. The hormone imbalance has been well into effect, and once you kind of lose those hormones and those receptors, they start to shut down and damage sets in, right? That's at that point, you, unreversible, right? So then you got the wrong hormone, synthetic. Today, it's bioidentical. Um, Synthetic. Give a little bit more information as to why our body doesn't like synthetic versus bioidentical.
Yeah. I always try to give like a lock and key analogy, right? Or like the thing I used to always say to patients is the difference between synthetic and bioidentical is the actual like molecular structure. So if I have the key to my house, right? That key specifically matches my house. When I put it into the keyhole and I turn it, it's the exact amount of ridges and everything. It opens up that keyhole or that door. And it's the same thing at the cellular level. If I have a molecule and that molecule docks at a cell receptor, right? It can actually fit into that receptor exactly as it's supposed to, right? Now, if I do a synthetic hormone, that's kind of like trying to put your car key into your house and turn it and open it, right? So it might go in, but it's not going to turn, it's not going to work as well because it's not exactly structured to match that receptor. And so when you don't have a complete match, you naturally have more inflammation, period, because it's not identical, right? It's not exactly what's supposed to be there. So then you naturally have more risks because you have more inflammation and you have more side effects because it's not biomimetic to what your body's naturally, used to.
Yeah. So then the other was that it used the wrong route. It used oral, so it increased VTE risk because
Yep.
it had to be processed through the liver, which increased clotting factors. Um, so a lot of things wrong with that study that the industry decided to make a decision on. So fast forward to today, right? Using bioidentical versus synthetic. Today, there's that window of opportunity when it comes to timing. So the right woman, right? We're when the timing makes sense is I guess is one of the questions I have for you is
Sure.
you know what I what I've learned is that it's for anybody who has a hormone imbalance, right? It isn't someone who's in menopause and in perimenopause. It can be any of those things, but it is critical for that to hit that window of opportunity prior to menopause. So let's talk about that. Let's stop and pause right there to talk about the window of opportunity.
I mean, just like with anything, and I'll get into specific studies and trials and findings and all that stuff, but just if we can just have a step back, right? Like take a big bird's eye view of everything. Just like with everything in medicine, let's just take diabetes as something like similar that we can compare this to, right? Diabetes, by the time diabetes is not inevitable, no matter what anybody tells you. Type 2 diabetes is not inevitable. I don't care what genetics say. There's a lot that goes into that in terms of lifestyle and diet and all kinds of stuff. But the point is that it's a progressive disease that happens over time. So you don't just wake up one morning fully diabetic, right? You start that shift, and you and I both know there's a blood sugar marker you can measure called HbA1c or hemoglobin A1c. Now tell me your average blood sugar the last 3 months. It's kind of like the lie detector test. It tells me what's actually happening. What do your sugars actually look like? Well, before you become diabetic, excuse me, diabetic, you become pre-diabetic. And that happens when A1C is getting the 5.5, 5.6 range and they're creeping on that, right? So you can either blow past that and ignore it and wait for the full-blown diabetes diagnosis, or you can actually be proactive, preventative, and slow that down, reverse it before you actually become diabetic and get control of the situation, right? And it's very similar analogy when it comes, because once you become fully diabetic, that's a much bigger ship to turn around, or to impact, I should say, right? Because you already have so much dysfunction and oxidative stress and blood sugar, dysregulation and pancreatic insufficiency and blah blah blah, right? All that's already happening. It's the same with hormones. If you wait until you are fully menopausal and then some, by the way, because 10 years into menopause is and then some, right? Then you've missed that opportunity to really target the body when it's in its prime and when you can actually have more impact being proactive and preventative. I'm not saying that, women, like if I don't want a woman in their 60s, 70s to hear this right now and think, oh, it's too late for me, I'm not going to get a benefit. You certainly will get a benefit. But if you have a choice and you're able to implement this stuff earlier, it's important to do so. And we have a lot of research to prove it. So, the two trials I talk about a lot are the Keeps and Elite trials. They came out in the 2010s. So I think Keeps was in 2012 and Elite was in 2016. And they both talk about, the importance of introducing hormones in that early perimenopausal phase. Specifically, they're around estrogen. We can tell there's a whole other conversation around testosterone, but specifically around estrogen, wanting to do it earlier. And if you do it earlier, you slow the progression of arterial aging, like the thickening of the arteries and the arterial aging. And by doing that, you can prevent a lot of those, inflammatory downstream effects, right? Increased cardiovascular risk, increased, inflammation, all that kind of stuff by intervening early. And actually, there was this actually made like a really big splash recently. I think it was in October. There was the Menopause Society. They had their annual meeting, and they came out with an article. And it's pretty wild, Zach. They looked at over 100 million women, right? They looked at over 100 million women who started estrogen therapy early versus during menopause. And they found that the women that started estrogen 10 years before menopause had a 66% reduction in their risk for breast cancer, heart attacks, and strokes. So research has known this. This is not new. We have known this forever. Again, it comes to the fact that we need to start having these conversations with patients and with clinicians, right? And so this is why we're here today, to really educate folks.
No, I think the exact number was like over 120 million,
Yeah.
which is insane, as well as just the fact that it showed the earlier that you start, you have a reduction of up to 60% risk, a reduced risk of breast cancer, heart attacks, and strokes. The same thing that basically people were scared away from, right? Um, starting early, right? Also known as the timing hypothesis with HRT, and why that's so important. You kind of said some of those things where, just estrogen receptors need that active environment to work. The longer that your body goes without it and deprived of it, those receptors start to downregulate. They become less responsive, and they start to lose their protective signaling. So that's why we're talking about early intervention, right? The sooner the better. When there's an imbalance or when you start having those symptoms, right? Because it's not just about, to your what you said earlier, not just about treating a marker, right? Because everyone's physiology is going to be different, right? You also have to have those conversations that you can't have with some of these telemedicine platforms, right? That are just doing testing, looking at your labs and making recommendations off of that, right? There's still the symptomology that plays a factor in the art of medicine, that you know comes down to you working with a very skilled, educated individual, who's able to look at those labs as well as work with you on your symptomology. Um, so that, having that early HRT, keeps those receptors active and responsive, to be able to deliver the benefits, and it's not just, the arterial flexibility that you get from it, but it's also going to be super impactful for brain health and bone health. So let's go a little bit more into, I don't know, do you want to go into the vascular protection first, or do you want to go into the neuroprotection?
Well, let's go through all of it and let's kind of break it down one by one, right? So, I mean, to your point, I mean, you're absolutely right. The longer you wait to introduce estrogen into the picture, right, those estrogen receptors, they kind of fizzle out. And it's just like, it's the same kind of mentality of like, you don't use it, you lose it kind of thing, right? So they just become less active. So even when you bring hormones in, they might not respond as well. So to your point, and you already made that, that's number one. The second thing is that vascular protection, right? So you need healthy arteries, and estrogen is anti-inflammatory and helps keep those arteries nice and pliable. They have a lot of protective mechanisms of estrogen when it comes to endothelial health and endothelial function. By the way, testosterone as well. But that's really important, is that you're not, if you,
And endothelial function.
yeah, vascular health.
Right. Give more definition of that for those who didn't go to medical school.
Just the function of your blood vessels, like how pliable they are. Are they able to move, or are they rigid and hard and more calcified, right? Because that's what's going to happen if you wait to replace estrogen until it's already gone and then some. You're going to have a natural hardening of the arteries during that process. And then when you reintroduce estrogen, you will not get the benefit you would have gotten if you had done it before you had the hardening of the arteries and the impact to endothelial function, they'll say. Um, but to your point too, right? Neuroprotective. Estrogen is so important for brain health. So is testosterone, but estrogen is so important for brain health. When you do it early, you're going to impact glucose metabolism in a positive way. Glucose is really important. Glucose is an energy source, right? And our brain is the biggest consumer of glucose, right? We're constantly thinking and talking and doing and all those things, and that needs energy. And so that makes sense, right? Why do you start to have so much brain fog and memory issues and focus issues? Well, you've lost that, the efficiency of glucose metabolism at the level of the brain, as well as the anti-inflammatory benefits of estrogen. Um, Estrogen is also going to promote neuroplasticity, right? Mitochondrial function in every cell, but also brain cells, right? So you're going to have, the ability to kind of restructure and build that brain and make sure it stays nice and healthy, over time. Bone health is by far one of the biggest things about estrogen. I think most people know this, right? Estrogen is really important for bone health in general. And when you start to lose estrogen, you start to have bone breakdown. So this is why maybe people don't make this connection, but this is why you see so much osteopenia and then eventually osteoporosis in your menopausal women that have not replaced estrogen, right? Because if we don't have that, then we start to have bone turnover. Bone turnover is going to increase, pretty significantly. We're going to see bone breakdown, and that's going to happen, and that's going to spike, especially with the loss of testosterone, right? Because testosterone is also important for bone health, and at this point, testosterone is gone. So if you intervene early with hormone, with estrogen replacement from a bone health perspective, it's going to reduce that bone resorption process. It's going to improve the survival of the osteoblasts that build the bone. And it's going to preserve that bone mineral density, so you have less risk for hypocalcemia, which is just a fancy word for low calcium. Um, you know, there's great impacts to the immune system and inflammation that we've talked about, because estrogen is so anti-inflammatory. It regulates cytokine production. It controls inflammasome activity, which is the fancy way of saying all your inflammatory molecules in your body. It has a massive control on how those different molecules turn on, turn off, and talk to each other. And it also plays a role in maintaining immune balance. Inflammation and the immune system are connected. You don't have one without the other. So when you don't intervene early enough, you're going to have a constant and chronic low grade state of inflammation, because you don't have that anti-inflammatory, protector in there. You're going to have increased autoimmune activity. How many women, Zach, and we can talk about your mom too, right? How many women have new onset autoimmune diagnoses in their 40s and 50s that seemingly come out of nowhere. I'm always told by patients, oh, it's genetic. My mom had it. Is it genetic? You're having all of this dysfunction in your immune system and your inflammasomes. And so then, you start to see a massive uptick in autoimmune disease in women in their 40s. So it's like your rheumatoid arthritis, your lupus, your Sjogren's, your undiagnosed or undifferentiated autoimmune diseases. This is really, really where you see that. The next thing I would talk about is just metabolic benefits, right? So estrogen is so important along with testosterone. And I keep bringing up testosterone because it needs to be part of this conversation, right? And we're going to dive into it later, but it's just not part of the conversation, even with all this amazing talk that's happening now around hormone replacement. But estrogen plays a super important role in fat distribution, in how well your insulin takes your sugar from your food into your cells to make energy, in mitochondrial function, how well as your cells make energy, as well as lipid metabolism. So just how well your body takes fat, breaks it down, and turns it into energy. And so if you don't intervene early enough, you're going to have all of that stuff impacted in a negative way. And like I said, it's all of these things together, right? So it's the heart health, the brain health, the bone health, the metabolic health, the immune health, the inflammatory health. All of it is related to this hormone decline. And if we can get in early, based off this timing hypothesis that again has been proven over and over again in research, then we can have such a dramatic impact on this stuff. And these women are not destined to have, 4 autoimmune diseases and all kinds of new mental health diagnoses and, increased risk for some really scary stuff long term.
Yeah, so just to kind of reiterate and recap everything that we just talked about, hormone therapy is directly tied to heart health, brain health, bone health, immune function and inflammatory effects, metabolic function, which obviously those are 6 key critical areas, which I'm not sure how much more you could have, such a profound impact on any other treatment or therapy. Um, but really outlining, the benefits of starting early versus the risks of starting late, right? Starting late when it comes to vascular function, right? The stiffening of the arteries and the plaque buildup. There isn't much that you can do when it comes to hormone, like when you do initiate hormone therapy. There's not much that can be done to reverse that damage. Not to say that there isn't other treatments or therapies that you could do, but it's not going to come from the initiation of hormone therapy because some of that
It'll just
damage.
be more comprehensive. It'll be more complex, is what you're saying. Yeah, I don't want to give them this. I don't want to say that you can't address those things. You can, right? But it takes so much more effort, right? It takes so much more effort, so much more that has to be thrown in the plan, right? And if and that's not easy. If you at a baseline are struggling with brain fog and pain, and you have cardiovascular risk and all these things, right? It's hard to do the
Yeah,
extra work requires to start to turn some of that stuff down and reverse it.
yeah.
So might as well do it early and prevent it.
Yeah, and then your neuroprotection, right? The estrogen that keeps the brain at a metabolic and an anti-inflammatory state. When you were deprived of that estrogen, there's also damage that begins to set in. That's where your brain fog, the low mood, the where you're going into the doctors and they're basically prescribing you an antidepressant because they weren't trained on hormone therapy and the phases that women are going through. Then you got your bone remodeling, like you said. Obviously, that is more prevalent for women than it is men. Um, but I mean, it's critical, right? I mean, because you hear about it all the time as women get older. The increased risk of fractures that they have, and we know as you age and you do have that fracture, um, just how debilitating that can be, and very quickly
And life threatening.
become a life threat.
Yeah.
Exactly, a life threat.
Yeah, and then the thing I would add to this that we didn't even talk about, but and again, kind of like nods to the gender disparity is sexual function. You lose that. Like we haven't even addressed it yet because it's not something that people address for women, but women deserve to have sex too. Women deserve to have great orgasms and great connections with people in that way. And when you lose your testosterone and estrogen, that stuff goes out the window, right? And women are just kind of told to suck it up and deal with it as if it's not important. But sexual, you and I talk about sexual health is a huge part of vitality, of life, of connection to others, and 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 not to mention, from an estrogen specific point of view, when you start to have the decline in estrogen, right? When estrogen is important for a lot of things, but one of the things it does is it helps lubricate the vagina, right? So then you have really, really dry mucosa down there. So for penetration, it's a lot more painful. And then you have a lot of increased risk for infections. You have a lot more pain with sex. So imagine what that's like for the average woman, right? They're in their mid to late 40s and they're having constant UTIs. They're having super painful sex, right? And there's no solution for them, or it's not even addressed as something that needs to have a solution. So I think that's something that needs to be talked about too. This is a sexual health piece.
Say sexual health is critical. I think that's something that we certainly need to hit on, especially when we get into the um, while why testosterone is also a huge critical factor. But I think there's so much to unpack here with the estrogen arm. um, like with the Women's Health Initiative, that what it actually showed about the estrogen alone, right? And to just keep in mind, right, this is estrogen that was still considered or was synthetic, as well as taken orally. But it did show extreme benefits from estrogen, which some people say that the main problem with that study was the progestin. Um, Even though we understand the risk that came with um, the oral form and obviously synthetic, but um, the fact that there was still some benefits. So let's talk about the benefits that the Women's Health Initiative showed just in the estrogen alone arm.
Well, this is like to your point, right? You kind of alluded to the fact that the like the synthetic progesterone that they used is the main culprit of a lot of the issues, right? So knowing that, and knowing you still have this great data set, let's go back and look at, okay, well, let's take progesterone out of the mix, right? The only time we give progesterone, we're giving estrogen is if a woman has a uterus, because estrogen will build up that lining of the uterus, which over time, if you're not getting a period because you're not having a menstrual period, normally the menstrual period, you would shed that lining and you would slough it off and it would come out in a menstrual period. But if you're not having a period and you keep having that build up, you can, have risk for hyperplasia, which is just a fancy word for more tissue building, which increases risk for cancer long term. So if we want to look at this data and really see what did without manipulating any results, what did their results show for the people that didn't get this synthetic progestin, but instead just got the estrogen, even if it's not in the perfect form that you and I would prefer, right? We would prefer a biomimetic, bioidentical, transdermal, or subcutaneous. But they did an oral and they did a synthetic, and those people, that one arm that got the estrogen, and they did not get the progestin because they don't have a uterus, right? They showed in that study a 22% reduction in breast cancer incidence and a 40% reduction in breast cancer mortality. So what does that mean? What that means is that not only were they less likely to develop breast cancer compared to women that took no estrogen whatsoever, but they were also significantly less likely to die from it. So the data is there, and it proves this benefit, but you just need to know how to interpret the data, and you can't always believe what you read in the media.
Yeah, and basically it just showed, even though we've been, through this medical dogma to fear that hormones are going to cause breast cancer. Um, the this study right here, in fact, proved that wrong. Right? It showed that if anything, balancing those hormones, there was a lower risk of breast cancer incidence. There was a lower risk of breast cancer mortality.
Right.
Um, so the very opposite of what we have been told all these years to fear. Um, while still at the same time using synthetic, using oral, which are two different things from what's being done today in the modern day bioidentical hormone therapy.
That's right. Exactly.
What this modern study reflects today, right, and the approach in terms of the safety and the timing. Let's talk about, you mentioned them earlier, the keeps done in 2012 and the elite trial done in 2016. Um, what those studies really showed us in the the prevention and proactive mechanisms of starting hormones early.
Yeah. I mean, we could break them down individually and just give a little breakdown of each. So the KEEPS trial is the Chronos Early Estrogen Protection Study or Prevention Study, and this came out in 2012. And really, what they looked at was, recently menopausal women, not just women 10 to 15 years past menopause. So they looked at a better population, and they used a low dose oral. Yes, it was still oral, so still not preferred method, but low dose oral estrogen, or they did a transdermal estrogen. So that's like a patch or a cream, plus progesterone. And what they found was there was no increase in cardiovascular events. And they actually saw a slower progression of atherosclerosis, which they were able to measure when that intervention is started earlier. So you not only have, no risk whatsoever from a cardiovascular event standpoint, but you slow down the progression of one of the most common and deadly cardiovascular diseases known to man, which is atherosclerosis, right? That's the beginning of the end for a lot of folks. Obviously they showed improvement in all their, vasomotor symptoms, hot flashes, night sweats, that kind of stuff, but also other components of health that are impacted by lack of hormones, right? Mood, sleep, focus, all those. So that was a KEEPS trial. And then in 2016, they came out with the ELITE trial, so early versus late intervention trial with estradiol. And same thing, its intention was to test this timing hypothesis by starting estrogen within 6 years of menopause versus the 10 plus years after menopause that had been done previously with the Women's Health Initiative. And what they found was the women who started it earlier did have that slower progression of hardening of the carotid arteries, and just overall slower arterial aging in general. So again, it just confirms and reconfirms that the KEEPS trial and everything else we're finding in the research about this. So the bottom line is, the earlier you intervene, the more from a cardiovascular protection standpoint, because that's what these two trials were around, the more protection you have, the slowed progression of disease, right? And that's what you're going for in terms of that.
Hope you found part one valuable. To delve further into testosterone for women, peptide therapy, and complete hormone optimization protocols that we use at Nava Health, watch part two now. Subscribe to Legacy and Longevity Podcast wherever you listen and follow us on Instagram and YouTube. If today's conversation sparked something in you, here's what I want you to do right now. Pick one strategy, one insight, one small action you heard today, and commit to it this week. Excellence isn't built in moments. It's built in the daily decisions that compound over time. Remember, you're not just building a healthier body or a more successful career. You're building a legacy that will outlast you. And that starts with the standards you set today. Thanks for listening to the Legacy and Longevity Podcast. If this episode was valuable, first subscribe so you never miss an episode. Then leave us a review to help more people find these conversations. And finally, share it with someone who you think needs to hear it. Until next Tuesday, keep raising the bar, keep pushing your limits, and keep stacking days. I'm Zach Dancel. Your legacy starts now.